The fusion of a sperm cell and an egg, smaller than the head of a pin, and yet within this tiny embryo, only a few gestational hours old, is the genetic blueprint that will direct the development of a new human being.
36-year-old female complaining of pain running down her left arm, diaphoretic. If you ever hook up to the monitor, ST segments are elevated, bag lactated running. What's your ETA? About 2 minutes away. Copy that. I want 4 units.
The body is in good shape. We don't get infected.
Exercise is extremely
That diet
important.
is not
Everybody is vulnerable to addiction.
Epidemic of obesity.
fries in a burger. It's the way to atherosclerosis.
Cancer is going to become the #1
Now
killer.
spending
Enjoy everything you can while you can.
Every cell of the human body, skin, brain, heart, lung, and liver, carries 23 pairs of chromosomes. And the chemical substance within each chromosome, the DNA, contains hundreds, sometimes thousands of different genes, depending on the size of the chromosome. It is the combination of these genes that makes each of us unique.
Genes are like beads on a string. Those strings are then packaged very compactly into the chromosomes. And we inherit one set of chromosomes from our father, one set of chromosomes from our mother.
Genes direct the formation of tissues and organs, hold instructions for all the chemical reactions that occur in the cells, and play a crucial role in determining our health and how long we live.
Fill them all up.
In terms of appearance, a lot of how we look is in our genes. All you need to do is to look at two identical twins to realize how genes are important for our hair color and our eye color and the shape of our nose and the shape of our mouth, how we carry our fat, how tall we are, how short we are, the shape of our bodies. All of these are controlled about 90 or 95% by our genes. When we start talking about internal things, your personality, who you are, whether you're a nice person or a not so nice person, whether you have a good sense of humor or a rather dour, then genes are also important, but to a lesser extent. Clearly, these aspects of our personality are more up to ourselves, more up to chance, and more up to the environment that we're brought up in. So there's really a sort of a gradient of how important genes are.
Genes are just DNA. They aren't destiny. Some aspect of our life experience, what we choose and what we do, how we form our character given our constitution, is what ultimately makes us the kinds of people we are. The idea that somehow or another we're destined because of genes to be a particular kind of person is not only not true in human life, but it's also, of course, not true in anything in life.
Occasionally, a chemical error in a gene can alter the body's biochemistry and cause someone to be born with an inherited disease, a physical or mental abnormality, or susceptibility to a disease. This was one reason the Human Genome Project was launched in the early 1990s.
The goal was to sequence the entire set of human genes and all of the material. There's a lot of material on these chromosomes. In between the beads and on the string, there's a lot of information that we don't understand yet, that appears perhaps to be junk, though I think many of us are reluctant to really call it junk. The goal is to sequence all of that so that we'll really be able to quickly identify genes and quickly be able to identify mutations. It's impressive to me that when I started identifying our first gene in my laboratory, it took us 7 years and many, many people. Now I can have a graduate student do it in an 8 to 10 week quarter and do most of it off the computer. We refer to it as cyber cloning.
Now we have the tools that allow us to look at the entire genetic blueprint, look at everything that individuals inherit to understand at least the genetic contribution to their function. Obviously, environment also contributes to function and disease, but knowing what genes are inherited by any organism is essential to a full understanding of how they operate and how they misfunction when disease occurs. There will still be some so-called finishing work to do over the next couple of years to get all the pieces together and fill in the gaps. And then the real work begins.
We then have, if you will, the periodic table of the human species. That's it. It's a big number, 300,000 or 400,000 total variants, but that's it. There aren't any more. So every trait, intelligent, height, weight, behavior, tendency towards addiction, tendency towards violence, everything is determined by one or more of those genes and their variants. Now, once you know them all, what are you going to do with that information?
One answer to that question can be found in this laboratory.
The Human Genome Project has revealed an increasing number of genes as the cause of genetic diseases. And once we have a gene in hand, we then, in quite short order, usually will have a gene test for it, a DNA test, which a lab like mine can offer. Most of the genetic testing we've done up till recently has been diagnostic, where a patient comes in with symptoms, and we just do the DNA test to try to pin down the precise name of the disorder they have. But now we have genes for late-onset adult disorders, such as familial cancers, neurologic diseases, such as Huntington's disease, where we can actually find the mutation and know that the patient is going to get the disease years or decades before the first symptom.
As I read,
The extraordinary advances that have occurred in diagnosing inherited disorders have also generated a host of complex social and ethical questions.
I see at least two major issues in the use of genetic information. One will be to develop the rules for risk assessment. So we can tell individuals, here are the diseases that put you for which you're at highest risk based on your genetic profile. The reason that's important is that that will be an inspiration to behavioral modification, which is currently difficult to achieve. Now, hand in hand with the challenge of using genetic information comes a societal challenge for all of us, and that is to ensure that we protect people's privacy and that we protect them against the discrimination that is likely to occur during their efforts to obtain insurance and to obtain employment.
Even at a personal level, how many people really want to know what the future has in store?
That's devastating news to get. It's a death sentence to get a positive result. I myself would not want to go through testing at this time because there's nothing that I would do differently with my life. If you get a positive diagnosis, then suddenly it can become a focus. And if you suddenly have a bad day where you drop something or you spill your coffee, you forget your keys, whatever, it would suddenly be like, well, this is it. This is the beginning of what's eventually the end. And I'd rather be able to just have normal bad days and not read more into it.
A lot of it depends on the disorder we're testing for, whether there's a treatment or not. But surprisingly, even the ones with no treatment, such as Huntington's disease, about half of the patients who are at risk because one of their parents had the disorder actually would like to get the testing and do want to know. You may say, why would they want to know this thing? It's so they can make certain major changes in their life plan, what kind of career they might pursue, whether or not to have children of their own, and so on.
How do you think the test is going to turn out? Do you think you will be found to have the gene, not to have the gene?
I think I'm going to have the gene. I think I am.
But I think I could go on, you know, with other things in my life rather than having it take up so much of my time worrying about it.
At this time, we're more studying rarer diseases, getting to know how those genes work, but we're using the same technologies now to move to the more common diseases.
So you might imagine many, many years from now that you go to your doctor's office and you have your gene map done, and it shows that you have a mutation that increases your risk of heart disease. Now, maybe the therapy at that time is to say, well, because that gene affects cholesterol, we'll put you on this cholesterol medicine now to prevent that from happening. Or maybe it would be so advanced that we transfer a gene in that modifies that gene and makes it correct.
The ultimate goal is that we'll understand these common disorders and be able to test for them and know that if I'm predisposed to diabetes, then I need to have ongoing testing to try and anticipate, perhaps in the future even prevent that disease or cancer or one of these other common diseases.
Well, as you know, the purpose of this visit is to discuss the results of your cystic fibrosis carrier screen, which we did.
Some couples request screening because of their family history. They're concerned that they may be carriers for a genetic-related disease.
When we're talking about recessive genetic diseases, those disorders only occur when a baby inherits two mutant genes, one from the mother and one from the father. If they just inherit one, they're just a carrier and they have no problems at all. So the issue comes up in pregnancy: should we be testing the fetus, or should we just do a carrier test on the two parents? And in general, we prefer, if we're given enough advance notice, to do the carrier testing in the parents first. And if both members of a couple are carriers, it means that they have a risk of 1 in 4, 25%, to have a child affected with cystic fibrosis with each pregnancy.
Such tests are generally offered only to couples who are at higher than normal risk.
We know, for instance, that Tay-Sachs disease is increased in Ashkenazi Jews and in some French-Canadian individuals. We know that sickle cell disease occurs in individuals that come from areas with malaria. We tend to think of it as an African-American disease, but in fact it can occur in individuals of Greek descent, of Italian descent, Mideastern descent, whose ancestors lived around the Mediterranean.
Yeah, if both parents are carriers, and then we do proceed with the prenatal diagnosis, and if the fetus is found to have the two mutations, and therefore we say this fetus is affected.
To find out if the fetus is affected, a physician collects a sample of amniotic fluid from the womb. Both the fluid and the fetal cells it contains are then analyzed for biochemical or chromosomal defects.
The fetus has the disease, or will show the disease in childhood or after birth. Then we have a number of options. We can do nothing, and some parents, it's interesting, even though at the start of the testing they say, yes, we want this test because we don't want to have a child with this disease, once they're actually in midpoint of the pregnancy, some of them change their mind and decide they just can't go through with a termination, and that's it from then on. Others will choose to terminate if it's an especially bad disease with little or no effective treatment. And then in more recent years, of course, there's the option to do some kind of therapy, even in utero gene therapy. I'd say much of this is still in the realm of research. It's not something we offer routinely to the couples.
In utero treatment is definitely something that's moving ahead. And I have been involved in situations where, for instance, a child had heart failure in utero. And they were able to treat the child with digitalis or other heart drugs. There are some surgical situations where treatment is being tried. One of the ones that looks extremely promising is neural tube defects. And there are surgeons who actually go into the womb, do surgery on the fetus, and then are able to close that over in utero. Normally that's done after delivery, but closing it in utero does seem to make a difference in the outcome for the nerve function for those kids below the defect.
The question that concerns many ethicists is, where do you draw the line? Which kinds of treatment are appropriate and which are not?
The scientific community understands that certain kinds of genetic manipulation are already here and acceptable. That is, introducing genes into individuals while they're alive, genes that won't be transmitted to offspring, perfectly fine. Many new vaccines are going to be based on the idea of delivering genes to individuals. Those genes will be expressed and will incite an immune response. We are doing gene therapy trials in many different diseases. Genes are delivered to individuals who lack certain genes. However, where most of us at this point draw the line is between what we call somatic or adult gene therapy and germline gene therapy, where the additional gene or new genetic information is actually placed in the chromosomes of the entire individual with the prospect of transmitting the tampered chromosome to new progeny, to offspring, to sons and daughters.
Of course, as we get to this kind of genetic manipulation, we go to that question of where do we stop? Do we stop only in correcting things that are identified as a disease, and then how do we decide and who decides what a disease is? Or do we say any change we can make, including adding greater capabilities, making a person perform at the highest human level, or even going beyond that? And these would be the questions that we would inevitably face as we have that greater ability.
One type of genetic screening that is not burdened by such long-term ethical considerations is newborn screening.
And the theory behind that is that some disorders you want to diagnose them as soon as possible after birth in order to do some medical intervention, because if you waited longer, there would be some irreversible effects. A prime example of that is phenylketonuria, or PKU, which is a metabolic disorder.
And this is a form of retardation that's due to a deficiency in a particular enzyme which converts certain foodstuffs into amino acids. If you're lacking that, you accumulate a toxic problem, a toxic chemical that poisons the brain and causes severe mental retardations.
PKU was a disease that I remember from when I was in a laboratory as a teenager, seeing kids who would come in who were autistic, who made no intelligible speech, who just rocked in a corner and hit their heads against the wall.
It turns out the solution is very simple, doesn't involve gene therapy, simply involves changing the diet so that that toxic product doesn't build up.
And now I see the kids with the same disease who are national merit scholars, who are doing just wonderfully and living normal, productive lives. And it's because of newborn screening and our ability to intervene early.
Every state screens newborns for PKU and congenital hypothyroidism. After that, there's great variance in what the states require.
Cystic fibrosis is one of the disorders that at least a couple of states are now doing newborn screening for. It's a little bit controversial whether that one you really need to catch early, but there's some data that shows that the patients who are diagnosed early and treated early with antibiotics and extra nutrition do have better growth rates.
Another area that's very interesting and is moving from general pediatrics into genetics, really, is newborn hearing screening. If you don't use your hearing organ, your ear, that then the connections don't get made, and you can't really make those connections for speech and language quite as well. But now what we're learning is that a significant percentage of those kids have genetic deafness, and that in fact much of the genetic deafness is caused by a single mutation. And so that I think we're going to go from a new kind of newborn screening, which is a functional test of hearing, to then matching that up with the blood spot on which the newborn screening is done, that we could then identify, do they have one of these genetic forms? Maybe there's even another kid at home who may have deafness that we hadn't picked up medically before.
The ability to improve the health prospects of a child offers enormous dividends, but for some expectant parents, that possibility doesn't exist.
To make an informed decision, they really need to recognize that this is the risk and whatever that risk is. And it's been very interesting to me to see how different people react. Some people are not fazed at all by a child who's going to have a severe malformation, have severe mental retardation. To them, that was just the chance they took with having any pregnancy. They're going to do the very best for that child. Others, families, perceive a risk of 2% as being a high risk for a disease. So trying to gauge and inform people so that they can approach the issue realistically, but within their own belief and value system is very important.
I assume my son's going to have this just because out of 3 siblings in my family, we all have it. And then I'll tell my son, I passed it on to you too.
We did take Rex's blood and we did test it. And the results of that test were that Rex is negative for the mutated gene, right?
Not every patient with the same genetic disease, even with the same mutation in the gene for that disease, will show exactly the same symptoms. Tay-Sachs is an example where it is uniformly a terrible disease. But there are other disorders that have a wide variability in their clinical severity. And one that's been talked about quite a bit is cystic fibrosis. It's generally not a happy disease. It's a serious lung disease and also affects other organs and tissues in the body. But whereas some patients with the disease die right in the newborn period, others will go on for an average life expectancy of 30 or 40.
When a child with an abnormality is born, parents need information as well as support from the medical community.
My main job in those situations is to help them understand what the situation is, what the child's capabilities will be, what they may not be, and then to help to get that child into the appropriate infant stimulation. I have seen Down syndrome change from when I was an intern and resident. Those kids, we just put them into institutions. We didn't have expectations, and they ended up significantly retarded, sometimes severely retarded. We rarely see kids that retarded from Down syndrome these days because infant stimulation has a major effect. So I believe it's very important to work with the family. There's so many families with these diseases that just become such champions for their kids.
In fact, it was just such a family, the Merton family, that influenced the direction of Dr. McCabe's professional career.
Back in 1976, when I was a fellow at the University of Colorado, and was asked by Dr. Marianne Guggenheim, a pediatric neurologist, if we would see these two brothers who were on the Clinical Research Center in the pediatric unit. She said, must be genetic. They look the same. They've got the same neurological problems.
Chris had gotten real ill, and they didn't know why. They thought maybe he'd been, abused and stuff. So we brought him to the hospital, and she took a look at that little one, wasn't walking. She said, there's something wrong.
Only 2 and 3 years old, Scotty and Chris were short, physically weak, and severely retarded with IQs in the 30s. They had triangular, elfin faces, crossed eyes, and sweet dispositions.
Those were the first two brothers with this contiguous gene syndrome that I've spent my whole career studying.
As McCabe and his associates were to learn, Christopher and Scotty had a rare combination of 3 genetic disorders. But at first, their condition was a puzzle.
It was not a trivial situation because they had been accused of child abuse. We now recognize that part of that disease is having thin bones, osteoporosis.
He was at a babysitter's, and he had broken his femurs. And I think that's why we were accused. Somebody beat him, and he wasn't. It was just real brittle bones.
I worked very hard to expunge that history from their record. It took me about 3 years, and they carried a letter with them from me in case anything happened.
The first clue to the genetic basis for the boy's condition came when the team analyzed their urine and found a high concentration of a sugar-like molecule called glycerol.
Chris has a deletion in the gene for glycerol kinase. We found that if you are completely deleted, if you don't make any of that gene product, any of that protein, then you will have severe disease. But if you have just a single amino acid change in an otherwise normal protein, that's where we can't predict the clinical picture from the mutation.
But that missing gene alone could not explain all the boy's symptoms.
Unfortunately, one of the tragic things in my career was that we didn't recognize the adrenal problem, the ability or inability of these kids to tolerate stress until after the youngest of the two brothers died following surgery.
His eyes were crossed, and the doctors felt, well, let's see if we can't help that. And they said that was routine, and then he got the flu when he got home. and then he died a couple days later.
The boy died at home. He had been discharged from the hospital. We had to get the body transferred across county lines and all of those things. But the family worked with us very hard, knowing the importance of this, not only to their surviving son, but also to other children.
As they looked back, other members of the family may also have had the same condition.
My little brother could have had this, yeah. They thought it was CP, and that's what it was wrote down as, because they didn't know.
9 months later, the older boy was sick with the same sort of thing.
His skin started to get rubbery. So I called Dr. McCabe, and they met us with just as soon as we got there, they took him back and brought him back in 10 minutes. They almost lost him.
Because they were afraid that he might die if it wasn't taken care of, and it was then that we made the diagnosis.
What they learned was that Chris also suffered from a form of Addison's disease.
When we're under stress, when we have an infection, part of our brain knows to put out a hormone that stimulates the adrenal cortex to make steroids. Chris doesn't have a normal adrenal cortex, so his mother has to become that regulatory instrument for him that is normally handled without us ever knowing about it.
Well, when he starts throwing up, we don't wait till he gets real bad. I usually up his dose and then wait an hour, and if he still keeps throwing up, give him a shot and then bring him right in.
Chris and his parents still keep in touch with Dr. McCabe as part of ongoing research, but also because of the close bond that has grown between them.
And every time I see him now as a man, I have to remember that he's been growing while I've been away from him. But he really enjoys what he's doing. He's got interest. He loves playing pool, going bowling, doing lots of things out in the community. And the community that they live in, Adams County, is really very supportive of Chris and provides him with ways that he can interact with other individuals and have a good social life.
And I know a lot of parents will hide their kids in closets, and I just don't do that. Even the worst retarded kids need to get out and feel the air. Just be aware of what's out there. Look into it. Don't shelter these kids. That is the worst thing you can do, is shelter these kids. They need to get out and explore.
Yeah, even little. Are there any other?
Fish.
Do they have fish? Oh, is it wet?
The Human Condition is a 26-part series about health and wellness. For more information on this program and accompanying materials, call 1-800-576-2988 or visit us online at www.intellicom.org.